Welcome to the Deep Dive, where we cut through the noise and zero in on the crucial topics that genuinely matter to you.
Guy there.
Today, we're diving deep into a health challenge for horses that's surprisingly common. It's often misunderstood, and it can lead to, well, devastating lameness. We're talking about how their bodies handle sugar.
Yeah, it's a complex area, but it's incredibly important. This deep dive is all about equine glucose tolerance and insulin dysregulation.
Right.
We're going to pull apart what it is, why it's such a big deal for our horses, and critically, the latest on how it's diagnosed and managed.
Okay, so our goal for you today, drawing from some really comprehensive veterinary research and specialist guides, is to give you that shortcut, to being truly well-informed. We'll distill the complex science down into the most important insights, maybe some surprising facts too, so you can quickly grasp the nuances of this critical health topic, and hopefully better protect the horses in your life. So let's jump right in.
Okay, so to really understand where things can go sideways, we first need a picture of a horse's normal metabolism.
Makes sense.
Think of horses as nature's continuous grazers, right? Their whole digestive system is tuned for a high-fiber, low-sugar, low-starch diet.
Very different from us.
Totally. And it's also quite unique how they continuously secrete both insulin and gastric acid. That's not how humans work.
And insulin's role in the system is, well, it's absolutely central, isn't it?
Definitely.
When a horse eats carbohydrates, its blood glucose levels, they naturally rise.
Yep.
This signals the pancreas to release insulin. Insulin then acts like a key, basically, unlocking cells in places like muscle and fat so they can take up that glucose from the blood.
Right. And it also tells the liver to store glucose as glycogen that's stored energy and to start making more sugar itself.
It's a pretty neat system. And there are other hormones too, like glucagon, cortisol. They work to make sure blood glucose doesn't drop too low, keeps it balanced.
Exactly. It's all about balance. And just to make sure we're all on the same page as we go through this, let's clarify a few key terms.
Good idea.
When we talk about glucose tolerance, we mean how effectively the body clears sugar from the bloodstream and keeps blood glucose levels normal after a sugary meal, maintaining that balance.
Okay. Then there's insulin sensitivity.
Right.
So imagine your cells have little ears listening for insulin's message. High sensitivity means they hear it loud and clear. Less insulin needed to get the job done.
Spot on.
Yeah.
And the flip side is insulin resistance, or IR. This is when those cells become a bit, deaf to insulin signal.
So they don't respond as well.
Exactly. And the pancreas, trying to compensate, has to pump out more insulin to get the same effect.
Okay. And all that extra insulin leads to hyperinsulinemia, which just means abnormally high insulin in the blood.
Correct. And this can show up in a few important ways. You've got compensatory hyperinsulinemia, that's the pancreas working overtime just to keep blood glucose normal despite the resistance.
Right.
Then there's exaggerated postcranial hyperinsulinemia. This is a massive, prolonged insulin surge after eating carbs, even if the horse's resting insulin levels are fine.
Wow. Okay. So even if they seem normal fasting, a meal can trigger this huge spike.
Precisely. And finally, there's basal, or resting hyperinsulinemia. This means insulin is just high all the time, even after an overnight fast.
And that's usually, 8 to 12 hours without grain or rich pasture? Low sugar hay is okay, though.
Yeah, typically. So if we bundle these abnormalities together, the resting high insulin, the exaggerated spikes after eating, the tissue resistance, we use the umbrella term insulin dysregulation, ID.
Got it. ID covers that whole cluster of problems.
Exactly.
Which leads us to a major condition often linked with ID, Equine Metabolic Syndrome, EMS.
Yes. This is characterized by that insulin dysregulation we just defined, plus increased body fat, either overall obesity or those specific regional fat deposits, and, crucially, a really high risk of laminitis.
That devastating hoof disease, we hear so much about it.
We do. And sometimes with EMS, you'll also see other issues like dyslipidemia, unhealthy fats in the blood, and adipokine dysregulation, which involves hormones coming from fat tissue itself.
And one more key player, especially in older horses.
Right. Pituitary bars intermediate dysfunction, PPID.
Yeah.
Commonly known as equine Cushing's disease.
Okay.
This is a neurodegenerative disorder, and it very commonly causes or worsens insulin resistance. It's a connection we absolutely have to keep in mind with older horses.
Okay, so that lays the groundwork. Normal function, key terms. Now, let's really unpack what goes wrong in insulin dysregulation.
Okay, so the core mechanism is peripheral insulin resistance.
Meaning resistance in the body tissues, not the pancreas itself.
Exactly. Those target cells, particularly in muscle and fat tissue, they just become less responsive to insulin signals. Insulin's knocking, but the door's slow to open, so glucose struggles to get inside the cell.
And what causes this resistance? I imagine obesity is a factor.
Oh, definitely. Obesity, especially that internal visceral fat, is metabolically active. It can actually secrete substances that mess with insulin signaling. But here's where it gets really interesting. Genetics.
Ah, the easy keeper connection.
Precisely. Certain breeds, ponies, Morgans, quarter horses, Arabs, some warm bloods, they seem genetically wired for this. They have what vets call a physiologic degree of insulin resistance.
Meaning it's sort of normal for them to be a bit resistant?
Kind of. Their bodies are just too efficient at storing energy. They clear glucose more slowly. It's like they evolved for feast or famine, and now there's only feast.
That makes so much sense. It's not just about overfeeding, though that plays a part. Their genetics set them up for it.
Absolutely. And speaking of diet, yeah, chronic overstimulation from too much non-structural carbohydrate, that's your starch, and sugar from grains or lush pasture,
Right.
that can genuinely desensitize those insulin receptors over time. It just wears them out, essentially.
And lack of exercise, just like in people.
Big factor. Physical activity naturally improves insulin sensitivity. So a sedentary lifestyle definitely contributes to IR.
Okay, what else?
Well, chronic inflammation, which often goes hand in hand with obesity, can also contribute. And as we mentioned, PPID in older horses. The excess cortisol from PPID directly causes insulin resistance. So if a horse has both, it's a double whammy.
Right. So all this resistance, the body pumps out more insulin, and that leads us to the really scary part, laminitis.
Yes, and this is the crucial link, so what does this mean? Moment. We now understand that those elevated insulin levels themselves are a direct trigger for laminitis.
Not just the obesity, but the high insulin itself damages the hoof.
Correct. The thinking is that insulin acts on specific receptors in the hoof lamellae, those delicate structures inside the hoof wall. This leads to abnormal cell growth, it compromises blood supply, and eventually causes that painful separation of the laminae. That is laminitis. It's a direct insulin effect.
That's a huge shift in understanding, isn't it?
It really is. It changes how we think about preventing and treating it.
It's interesting, though. You mentioned horses rarely get full-blown diabetes like humans do.
Yeah, that's right. Unlike type 2 diabetes in people, horses almost never progress to complete pancreatic beta cell exhaustion, where they stop making insulin altogether. Overt diabetes mellitus is incredibly rare in horses.
Good to know.
Also, remember that exaggerated postprandial response? Even if a horse has normal resting insulin,
Yeah.
some ID horses will still have that massive, prolonged insulin spike after eating sugary feeds, and that spike itself significantly increases their laminitis risk at that moment.
Okay, so it's not just about the baseline levels. Those spikes matter, too.
They really do.
So we know what goes wrong and why it can lead to laminitis, but how do you, the horse owner or caretaker, actually spot the signs?
Well, sometimes the clinical signs of ID or EMS can be a bit nonspecific, or they only become really obvious once laminitis is already struck. But a key indicator is adiposity, and that's more than just general obesity, although a body condition score of, say, 7 out of 9 or higher is definitely a red flag. What's often more telling are those distinctive regional fat deposits. You can see these even in horses that might look like they have a normal overall body condition.
Like the cresty neck.
That's the classic one. A firm, enlarged neck crest. Vets often score it from 0 to 5, and a score of 3 or higher is suspicious.
Where else might you see these fat pads?
You might notice them over the tail head, sometimes behind the shoulder, even above the eyes, or around the sheath in male horses or the mammary glands in mares. They're quite distinct bulges.
Got it. And then, of course, there's laminitis itself.
Absolutely. Current or past episodes are massive red flags.
What are the signs? Acute versus chronic.
Right. Acute signs are sudden lameness, often severe. You might feel heat in the feet, strong pulsing in the digital arteries down by the pastern.
The bounding pulses.
Exactly. And that classic stance where they lean back, trying to take weight off their toes.
Okay. And chronic signs. Things you might see over time.
Chronic signs show up in the hoof structure. You might see abnormal growth rings, maybe separation in the hoof wall, a widened white line where the wall meets the sole. Sometimes the hoof develops a dished profile, sort of concave. You might also see recurrent sole bruising, just chronic foot soreness. And on x-rays, you can actually see if the coffin bone inside the hoof has rotated or sunk.
And pasture-associated laminitis is really common with these horses, right? especially spring and fall.
Incredibly common. Those lush growth periods are high risk.
Are there other signs, maybe less obvious ones?
Yeah, sometimes. Things like reduced exercise tolerance, just general lethargy, maybe poor performance. Less commonly, you might see altered sweat patterns or even infertility in mares if the ID is severe.
And for older horses, we have to keep thinking about PPID too.
Always, especially if the horse is, say, over 15. Look for those concurrent signs. Hirsutism is the big one, that long, curly coat that doesn't shed properly. Also, increased drinking and urination, polyuria polydipsia, or PUPD, muscle wasting, especially along the top line, recurrent infections like foot abscesses or skin issues, and of course, recurrent or really severe laminitis is a hallmark of PPID too.
Okay, so lots to look for physically. But how do vets definitively diagnose what's going on metabolically?
It's really a combination approach. Diagnosis isn't usually based on just one thing.
Right.
Your vet will start with a thorough clinical assessment. That means getting a detailed history diet, exercise, past laminitis, changes in body condition. Then a careful physical exam, scoring that body condition, the cresty neck, feeling for those fat pads, and a really good hoof exam.
And then blood tests.
Usually, yes.
Yeah.
The next step is often baseline blood tests as an initial screen. Ideally, you collect the blood in the morning after an overnight fast again, 8-12 hours off concentrates and lush pasture, but low NSC hay and water are okay.
Okay.
Now, here's a really important point. While a single high resting insulin level can be suggestive, lots of horses with ID, especially early on, might actually have normal resting insulin.
Oh, really? So a normal test doesn't rule it out?
Not at all. That's why dynamic testing is often necessary for a definitive answer. Baseline glucose is usually normal too, because the high insulin is doing its job, keeping glucose down unless the condition is really advanced. Sometimes elevated fasting triglycerides can also point towards EMS.
And you mentioned things like stress or pain can affect these results.
Absolutely. Stress, pain, even some medications like steroids or certain sedatives can really alter insulin and glucose levels. So the vet needs to consider the context.
Okay. So if baseline tests might be normal, what are these dynamic tests?
These are the gold standard for really assessing how the horse handles insulin. They challenge the system. The most common ones done in the field are the oral sugar test, OST, or the in-feed oral glucose challenge.
What's the purpose of those?
Their main purpose is to see if the horse has that exaggerated insulin response after eating something sugary. Remember that postprandial hyperinsulinemia? These tests are designed to provoke that if it's going to happen. And they're generally more sensitive than just checking resting insulin.
How do they work generally?
Well, after the overnight fast, the horse gets a specific dose of corn syrup, usually Carolite syrup or dextrose powder, often mixed into a small amount of low-sugar chaff or feed carrier.
Okay.
Then blood is drawn usually 60 to 90 minutes later for the OST, or maybe 2 hours later for the in-feed test, and the insulin level is measured. If it's above a certain threshold, say over 45 or 60 microunits per ml for the OST, maybe higher for the in-feed test that concerns insulin dysregulation.
So it's a practical way to test that meal response.
It is pretty non-invasive. The main limitations are making sure the horse eats it all and getting the timing right for the blood draw.
Are there other more involved tests?
Yes, there are. Things like the intravenous glucose tolerance test or the combined glucose insulin tolerance test, CGITT.
IV tests. Sounds like a hospital setting.
Usually, yes. These tests bypass digestion altogether. Glucose, and sometimes insulin, is given directly into the vein via an IV catheter. Then blood glucose and insulin are measured at specific time points over several hours.
What's the advantage?
They give a really robust picture of how well the tissues are actually responding to insulin, that tissue and insulin resistance piece, without the variability of digestion. They are more involved, require catheters, and multiple samples, so typically done at clinics or hospitals.
Okay. Any others?
There's also the insulin tolerance test, ITT. This involves giving insulin intravenously and measuring how quickly blood glucose drops, which shows how well tissues take up glucose. But this one carries a significant risk of causing severe hypoglycemia, low blood sugar. So it needs extremely careful monitoring and is used less often.
Got it. And just to circle back for older horses, testing for PPID alongside the ID test is standard practice.
Absolutely critical. Testing for PPID with things like the baseline ACTH test or the TRH stimulation test should be part of the workup in any older horse suspected of having ID. Treating PPID can make a huge difference to the insulin regulation.
Okay, so we've covered the signs, the diagnosis. Now the big question, once ID is confirmed, what can actually be done?
Right. And the good news is Management is largely based on lifestyle modifications. Diet and exercise are key. Medication often plays a supporting role, but lifestyle is the foundation.
So starting with diet.
Definitely. Dietary management is the cornerstone. The main goal is to drastically cut down non-structural carbohydrate, or NSC, intake, and also promote gradual safe weight loss if the horse is overweight.
Which means less grain.
Pretty much eliminate or minimize concentrates, grains, sweet feeds, anything with molasses. The focus shifts to high-quality grass hay with an NSC content of less than 10–12% on a dry matter basis.
And you really need to test the hay to know that number, right? You can't just guess.
You really can't. Hay analysis is one of the best investments you can make for these horses. It takes the guesswork out.
Okay. And you mentioned a practical tip about soaking hay.
Yeah, this can be really helpful. Soaking hay in water for about 30 to 60 minutes can significantly reduce the soluble sugars, like fructans and glucose. Some studies suggest longer soaks, even up to 12 hours, but you lose more nutrients then. Critically, you must discard the soak water afterwards. Don't let them drink it.
Good tip. What about pasture?
Pasture access usually needs careful management or restriction. Lush, rapidly growing grass, especially in spring and fall or during sunny but cold conditions, is very high in NSC.
So grazing muzzles, dry lots.
Exactly. Grazing muzzles can limit intake, or keeping them in a dry lot with tested low NSC hay is often the safest bet, particularly during high-risk periods or if they've had laminitis.
And for weight loss, how much hay should they get?
The standard recommendation is to feed hay at about 1.5% of a horse's ideal body weight per day, not their current weight if they're obese. This promotes slow, steady weight loss. Weighing the hay is crucial here.
Right, not just feeding by the flake.
Definitely not. And make sure they're still getting essential nutrients. Use a low NSC ration balancer pellet or a vitamin mineral supplement to cover their nutritional needs without adding significant calories or sugars.
Okay, diet is huge. What about exercise?
Incredibly vital. A consistent exercise program directly improves insulin sensitivity, makes the cells more responsive, and obviously helps with weight loss.
How much? How often?
Start light, especially if the horse has a history of laminitis, and gradually increase the intensity and duration. The key is consistency. Some form of daily activity is ideal if possible.
But a really important caution here.
Yes. Exercise must be managed very carefully, or sometimes completely avoided if the horse has active laminitis. Their comfort and hoof health have to come first during an active episode. Once they're sound, exercise can be gradually reintroduced.
Makes sense. So diet and exercise are the mainstays. What about medications?
Medications are usually adjunctive, meaning they work alongside lifestyle changes or they target specific underlying causes.
Like PPID.
Exactly. If PPID is diagnosed, the drug pergolide mesylate, the brand name, is Presend, is the primary treatment. By controlling the PPID, it often significantly improves insulin sensitivity and glucose regulation as a secondary benefit.
Okay. What if there's no PPID, just primary insulin dysregulation? Are there meds for that?
Yes, there are options.
Yeah.
What's fascinating is the use of levothyroxine sodium, which is thyroid hormone.
Even if their thyroid is normal?
Yes. Even in horses with normal thyroid function, vets sometimes prescribe it short-term, maybe for 3 to 6 months. It actually increases the horse's metabolic rate, helps promote weight loss, and improves insulin sensitivity in those obese, resistant horses. It's like a tool to help kickstart the metabolic improvements alongside diet and exercise.
Interesting. What else?
Well, a real game changer that's become much more common recently are the SGLT2 inhibitors, drugs like canagliflozin or tugliflozin.
How do they work?
They work in the kidneys. They block a protein called SGLT2, which normally reabsorbs glucose back into the bloodstream. By blocking it, more glucose gets spilled out into the urine.
So the horse essentially pees out excess sugar.
Basically, yes. This effectively lowers both blood glucose and, importantly, blood insulin levels. They are proving highly effective, especially for horses with persistently high insulin, despite diet changes, or those with active laminitis linked to ID.
Are they approved for horses?
They're currently used off-label, meaning not specifically licensed for equine use yet, but their efficacy is really impressive, and they're rapidly gaining widespread acceptance based on research and clinical results. Vets using them need to monitor for side effects like increased drinking and urination and potential electrolyte shifts.
Okay. What about metformin? We hear about that for human diabetes.
Metformin is used in humans, but its effectiveness in horses is, well, less consistent. The main issue is poor oral bioavailability. Horses just don't absorb it very well from their gut. So while it's sometimes tried, it's rarely a primary treatment for ID in horses.
Good to know. And finally, managing the complications like active laminitis?
That requires aggressive, immediate care. Things like strict stall rest on deep, supportive bedding, pain management with anti-inflammatories, therapeutic shoeing or trimming to support the hoof, and often cryotherapy, aggressively icing the feet and lower limbs to reduce inflammation and pain. That's a whole topic in itself.
It sounds like it. Okay, so with all this management, what's the outlook? The prognosis?
Well, the good news is that with strict, lifelong adherence to the right diet, exercise plan, and appropriate medical management if needed, most horses with EMS or ID can be managed really well.
So they can live comfortable lives.
Yes, they can control their insulin dysregulation, significantly reduce their risk of future laminitis episodes, and often return to some level of work or activity.
That's encouraging. But what's the reality if it's not managed well?
The reality is that EMS and ID are chronic conditions. They require lifelong vigilance. Untreated or poorly managed cases often lead to progressive, recurrent laminitis, intractable pain, and sadly, a significantly reduced quality of life that can necessitate euthanasia. It really highlights why understanding and managing this is so critical.
Absolutely. Which brings us to prevention. How can we try to stop this from happening in the first place?
Prevention is definitely key. Early identification of those at-risk horses, the easy keeper breeds we discussed, is crucial. Start managing them appropriately from a young age.
Like preventing obesity.
Exactly. Prevent obesity right from the start. Feed an appropriate low NSC, forage-based diet suitable for their type and workload. Avoid overfeeding concentrates just because, everyone else does.
Right.
Encourage regular, consistent exercise and turnout. And consider proactive screening.
Meaning testing horses even if they don't show signs.
Yeah, especially in those at-risk breeds or individuals. Maybe baseline insulin testing or even an OST before clinical signs like fat pads or laminitis develop. Catching it early makes management much easier.
And for older horses, regular PPID screening.
Definitely. Annual screening for PPID is recommended for horses over 15, maybe even earlier in some breeds, because treating PPID early can prevent or mitigate the associated insulin dysregulation.
Okay. Wow, we've covered a lot of ground.
We have.
We've really unpacked the complexities here from normal metabolism, what goes wrong with insulin, the signs, the tests, and the management strategies, and crucially, that direct link between the metabolic issue, the hyperinsulinemia, and laminitis.
It's a paradigm shift, really, understanding that high insulin itself is the trigger.
So here's a final thought to leave our listeners with. Given how central diet and exercise are in managing ID, and knowing that laminitis is often a direct result of high insulin, what other aspects of how we commonly manage horses today, things maybe we take for granted, might be inadvertently contributing to this widespread problem? And how could we proactively adjust how we keep horses to better align with, how they actually evolved to live and eat?
That's a really important question to ponder. Are our modern practices setting some horses up for failure metabolically? It's definitely food for thought.
We hope this deep dive has given you clarity, a robust understanding of this crucial topic, and empowers you to better support the health and the well-being of the horses in your life. Thanks for joining us.
Thanks, everyone.